Hi, good evening and welcome to tonight's CPD Me webinar. My name is Andrew Ormrod and I'll be facilitating the webinar tonight, and I'll very shortly be handing you over to Ben Spashett, who's a critical care paramedic talking pre-hospital ECGs. And this is part one of a few series, so please do tag along and make sure that you follow this series of webinars. Just a webinar fact for those people who are not particularly familiar with our webinars. We can't see or hear you, so if you're sat there in your knickers, or you're sat there in fact with your dressing gown on, or in fact whether you're in fancy dress because it is Christmas, we can't see you and we can't hear you. So whatever your attire is, please just make yourself comfortable. In fact, pop your slippers on if you like. It's entirely up to you. We can already see that people are popping in the chat, so pop in the chat tonight where you are dialing it in from. Maybe tell us, in fact, what you do for a living and what interests you about ECGs, whether you're an experienced practitioner maybe, or whether actually you're just looking for a refresh. But it's always good in the chat box to tell us where you're dialing in from, and I'll do some interacting with you shortly in there. If you have any questions for Ben, then please do pop it into the question and answers box, and of course we'll try and answer them at the very end, and we'll get through as many as we can within this framework. And so please do pop them into the Q&A box. I can hear Ben laughing in the background.
I know some of these names.
Yeah, I'm sure they'll tease you. I'm sure they'll tease you. So if you are a premium member of CPD, you will get a CPD certificate, and that will come out first thing in the morning once my admin team wake up and they've had the first cup of coffee. It's usually about 10 o'clock. And if you have got the CPD Me app, then the app will notify you when your certificate's arrived. And then, of course, we want you to go in there and reflect about what you've learned and how that's going to influence a change of practice. And that will complete your little CPD journey magically. Everybody will get a copy of the recording, and that will be sent to you after the event, so you will get a copy of that. And of course, the CPD certificate will drop automatically so that you can very easily reflect on your learning journey. If you have got a mobile phone to hand, then you can scan the QR code. There's a few opportunities tonight to scan the QR code, so please do make sure you have your mobile phone to hand. Or if you don't scan the QR code, actually, it's really good to catch the screen quickly, and then you can go back and look at those later if you need to. If you are on Twitter, please do follow us at CPDMe, and it's always good to see what you're up to tonight, whether you're sat there making mulled wine or in fact you're making mince pies. Please do tag us in with at CPD Made Simple, at CPDMe of course, and then I'll do a bit of engaging with you while Ben's doing his presentation. If you're not a member of CPD, it's absolutely fabulous for making sure that you capture and record your CPD, and of course have it prepared and ready for either interview, audit, HCPC, NMC, GMC, ABCD, EFG, whoever your governing body is. CPD will support you to build and maintain that accurate record of your CPD. So please do download the app. The app's free of charge to download. And our premium membership is £1.99 for a month, or it's £15.99 for a year. And for that premium membership, you get 80 live CPD webinars per year with automated CPD certificates. And you also access our CPD bank of previous webinars, where there's around 200 to 300 CPD webinars, all again with automated certificates. So 15 quid per year. It's about 4 cups of coffee in my calculations. But so please do either scan that QR code or jump over to the website and have a look at our offers. If you do follow us on YouTube, sometimes we get significantly oversubscribed on these webinars. So if you're ever struggling to catch up or you can't dial in because the room's shut, please do jump onto our YouTube channel where you can capture. It runs about 3 minutes behind on YouTube, so it's always good to jump onto YouTube and have a catch up where you need to come to next. Competition time. So please do genuinely leave us some feedback. It's always good to get some genuine feedback from you. So please either leave us some feedback on Trustpilot, on the Google App Store, or on iOS Store, or indeed on Google. And what we can do tonight is I've got actually a little bundle of prizes, which I'll reveal at the very end. So I've got 2 big bundles, including scarves and hats, because it's getting that time of year, that I will send out and make sure that we announce the winners, whoever's popped some feedback for us at the end of tonight's presentation. If you do like promoting CPD at work, then please do download our CPD poster, and our CPD poster will allow you to capture all of our up and coming CPD webinars, and you can either download that or share it digitally, and that ensures that even when there's a live webinar that's passed, when you scan that QR code, it'll actually take you through to the recording, so it ticks all the CPD boxes. I've just realised that I'm sharing all of my screens tonight, so you can see what's coming next. So you'll probably already realise that actually now's the time to hand over to Ben. So are you there, Ben?
Hello. Yeah, can you hear me okay?
Yep, perfectly. I'm going to hand over the screen to you now.
Brilliant. Do I still need to click share screen? That's not. Yeah, that one. Good. Hello and welcome. Firstly, thank you for CPD me for having me back. I did one about 4 or 5 months ago, the dangers of a long lie, and today we're going to talk about pre-hospital ECGs. I did get asked before doing this, so like, you know, who I am and where I've come from. So, wrong screen. I want that. There we go. So who am I and why am I here? How come I have the pleasure of being here? Well, I had the pleasure of qualifying as a paramedic just over a decade ago with LAS. And, you know, this is me in my powered hood for CCAM. I work as a critical care paramedic out of Gatwick. And over the years, I've done loads of different jobs. I've also been a 2-star. I've also had a couple of other jobs working with resilience and so forth. And I thought if I'm having all these pictures, I thought it's at least have a picture of me with the lady of my life as well. And there's a picture of me and my little dog. So we've kind of already briefly touched on it, the plan. I plan to do a series of pre-hospital ECGs. And as we go through each one, they're just going to hopefully add on to your knowledge. And by the time we get to the end, hopefully you'll be quite proficient. And today we're going to look at the principles. The second one, which I think's early January, we're going to be looking at AV blocks, left and right bundle branch block briefly, and Wolff Parkinson White. The third one, we're going to be looking at the QRSs, including ST segment changes and what happens and what we need to do. Then we're going to look at just the T waves. And then the fifth one, at the moment, I haven't given it a title. And the reason being is that I want to know what feedback you guys give me. If there are certain things, burning questions you have, or something that you really want to cover about pre-hospital ECGs, I want you to email me. I want you to email the team, and I want them to feed it back to me, and then we'll come up with a program. My initial thoughts was to look at things like, you know, too fast, too slows, hypothermia, when people have a neurological event, why does that change the heart? When people have maybe liver or kidney failure, why does that can change the heart? Those types of things. And then I think we're planning on maybe having a Saturday morning. And this is going to be the real icing on the cake. This is going to be the real kind of cherry. It's going to be the whole lot. And it's the tips and tricks. Is even if you're not that proficient at reading ECGs, if you have a good, solid, systematic approach to these ECGs, you're never going to miss an unwell ECG. Now, language. I do this for a lot of my presentations. I don't know who's here. Like, I've noticed Andy Collin is here, who I know Andy. I've known Andy for years. And also I've spotted a colleague of mine, Will, as well. So we've got a consultant paramedic at one end, and we've got someone who's starting their paramedic journey at the other. Now, I'm sure that Andy's aware of all the big long terminology when it comes to cardiology, but yet some other people out there may not be. So when I talk about language, you may hear me use the term myocardial infarction, for example. I know what that means. Some of you guys may know what it means, but some of you may not. So what I'll do, I'll say myocardial infarction, and then I'll use the term heart attack, which is almost the layman terms. There is, sometimes there is slight fundamental differences, but I want everyone to understand what I'm talking about. There are certain words, when we use a word, say, for example, ischemic, there isn't really a layman's term. So I may use the word ischemic and then go on and say where that organ, liver, whatever, is suffering because of a lack of oxygen or nutrients. So give a brief description. And also this word that I've put up on the screen, I can't pronounce it. I'm not even going to attempt to pronounce it. That is the longest word in the English dictionary, and also it's some kind of medical thing. I can see the pneumonia and I can hear the osis, so it doesn't sound pretty good in the first place. Through this session and all the others, we have to remind ourselves we are not cardiologists. And I think that's really important. During my education journey, I've spent time in St. George's A&E and in cardiovascular and all these other places. And it's really interesting that you take a wonky ECG into A&E and the doctor looks at it. If they're not sure, who do they take it to? They take it to the consultant. If the consultant's not sure, who do they take it to? They take it to the cardiologist. If the cardiologist is not sure, they just keep passing these things up the chain. And we always have to remember that. So how can we be overly proficient when the ED doc may not be, or even the ED consultant may not be, or even that junior cardiologist may not be 100% accurate in what they're looking at? Specificity and sensitivity. We were having a great conversation before we started this. What do I mean by specificity and sensitivity? Because this is really important that we understand this. Let's just say you're at home and you decide to fit a burglar alarm and you set it to record everything. You've never been burgled before, you just like the idea of having one. And you wake up the following morning and you realize that you've got 55 alarms gone off. Oh my God, I didn't realize I lived in such a rough area. So you check the footage back and you realize that one's just a badger crossing your driveway. One is just the wrong type of leaf. One's just a tree in the background waving. One's just a car going past the road, and one's a bag. It's a sketchy looking bag, but it's just a bag. And you realize you haven't been burgled at all, but you've set it so high that that's all it's going to pick up. So you change it. You change your burglar alarm to look for a male wearing a grey hat, black mask, with stubble, brown bag, black and white top, black trousers, grey socks, black shoes. Following morning, you wake up. You haven't been burgled. There's no trigger set. Perfect. Weeks, days, months go past, and you wake up one morning and you realize I've been burgled. So you go and check the footage, or you go and check and you go, oh, I've got no markers. It hasn't come up. I would look through all the footage and you find the burglar. But you realize this burglar has a black cap and a black bag, and the bag says swag. Now, why is that important? We have to understand that sometimes we may not always get it right. It's what they call false positive or false negatives. So we just need to make sure that we're working safely. And I say this when I've taught this subject before. I would rather you, in the middle of the night, stand in front of an A&E doctor, consultant, whoever it is, even a PCI lab with an ECG, and they go, why have you brought this to me? This is not suitable. As opposed to leave someone at home who has got some kind of changes, and you're not sure about them, and you think it's going to be okay, and something bad happens. I'd rather us that sometimes we slightly over triage some of these patients. And I think that's really, really important. So learning outcomes over the next, it's going to be about 45, 50 minutes. Basic structure, lead placement, why up, why down, what bit does what, and when it goes wrong. So number 4 and number 5 are what we're really going to concentrate on. But I think it's important because we're just looking at the principles of, I think it's really important that we do just get a little bit of grounding. Because as I say, I don't know what any of your educational backgrounds are. So we look at the basic structure. And also we have our SA node. We have our pacemaker, nice at the top. We have our AV node, which is the next one down. Our bundle of His, then our left and our right bundles. There are more branches to that. We could talk about Purkinje fibers, we could talk about the BRCA branch, we could talk about all of that. But for us, the pre-hospital clinicians, we're not overly too worried about them. We just need to know the basic structure, the real fundamentals of it. We talk about lead views. I'm going to say this once, limb leads are designed to go on the limbs. That's where they go. We're not going to sit here and talk about the Bayer hypothesis. Find me at a later date and we can chew the fat on that one. But the limb leads go in a certain place and those calculate some views. The chest leads, as it says, goes on the chest. Now, the chest leads are not calculated. They are looking at exactly where you place that lead. So if you place that lead, not necessarily in the wrong place, but in a place that's not quite where the heart is, you may not get the reading you think you might get. We always have this preconception that the 4th intercostal space on the left-hand side is where the plug, for some people it is, but for some people it isn't. It may actually be the 5th intercostal space or even the 3rd. So we use these landmarks as a general purpose. And in my world, if I think I've got a tall patient, I'll just slightly wiggle them a bit, move it down a bit to see whether I get a better view of these views. Electricity. When we talk about ECGs, when you have your ECG dot, especially the chest leads, it can only see electricity that's moving directly towards it or away from it. It cannot see any electricity that's cutting across it, only towards and away, okay? And that's really important. And this is the bit that normally blows people's minds. When we talk about electricity, we have to have a positive and a negative. a plus and a minus, as you would see on a battery. So if I have positive electricity moving towards a positive electrode, that's going to go above the line, a positive deflection. If I have positive electricity moving towards a negative electrode, I'm going to have a negative deflection. And the third one down, positive, if it's not moving towards an electrode, you're not going to see anything, meaning the deflection, you're also not going to see anything. So that's the depolarization. And the repolarization is just in reverse. And I'm sure some of you have sat there now going, I thought this was the principles. This is blowing my mind. I don't understand. That's okay. We're going to talk about it a little bit more. I've got my little cursor. So here we go. We've got A. This is positive electricity moving towards this ECG dot. So what we see when there's nothing moving at all, it's isometric. So isometric is its starting point. Then it moves towards it and we get this spike up. And as soon as it stops, it has to go back to where it starts. Okay. Once again, if this is positive electricity moving away from the ECG dot. So once again, if there's no movement, we have this starting point. So now it's moving away as it goes down, and then it stops, and it must return back to normal, or back to the starting point. It must return back. It can't float around, it must return back. Okay. So same thing. Now we're going to put it in relevance to a PQRST. So as you can see, we've got our negative and we've got our positive. For the heart to contract, we need the positive electricity. So we can start at the SA node and it fires off, goes to the AV node. And that's why we get our P wave. Now, some of you may answer, well, surely that should be spiked. Yes, I agree with you. There's a reason why it's that shape. Ask me the question later and I'll explain to you why. Then it holds on to it for 3 to 5 small squares. We'll cover that a bit more. And that just allows blood just to flow from the atriums down into the ventricles. Then we have this skip over from the atriums to the ventricles. Sometimes this can generate a bit of a Q wave. We're not going to focus too much on Q waves today because that's definitely going to spoil the fun for session, I think 3, maybe 4 later on. And then we have the main part of electricity. As it shoots down the middle of the heart towards this plus sign, what do we get? We get this nice big R wave. And then it wraps itself around the heart. Now, because it wraps itself around the heart, it may not be directly moving away because it's now moving away from the ECG dot. So as you see, it's kind of moving in this direction. So then we get this S wave. On this particular view, it's not that big. But in other views, it may get bigger if we're doing a 12 lead. And then it stops. It's contracted, it's squeezing the blood out, and off it goes around the body. But we need to have this repolarization. So, as we said before, if I've now got a negative moving away from a positive, as we get this wash over it, we get this positive T wave, okay? As I say, we just need to know this bit at this point. All the smart people have already figured this out for us. We're not going to sit here and dissect every single bit of why this, that, and the other. That's what we need to know, okay? So here it is, the same picture, slightly different demographic. We've got our P interval, we've got our P wave duration, we've got our PR segment, QRS, ST segment. We're not going to worry too much about the J point today because we've got a whole section on ST segment changes. Our T wave, we're going to cover that a little bit today, but there's going to be another whole session of it. U wave, I have no direct plans to talk about U wave in any of these sessions. If you want feedback or why U waves appear, put it in the column, put it in the comments, speak to CPD me, and I'll add it into the 5th one. If that's what you really, really want to learn, then I'll obviously add that in. So let's get cracking. P wave. The PR interval is the time from the onset of the P wave to the start of the QRS complex. It says QRS complex. If there's no Q, it will be the R. It reflects conduction through the AV node. The normal time is 120 to 200 milliseconds. 3 to 5 small squares. That's how I always remember these things, 3 to 5 small squares. So we know it's 3 to 5 small squares, but what we don't know, or what you may not know is what happens, what's the problem if it's too long, or there's no QRS after the P wave? What happens if the PR interval is too short, less than 3 small squares? What happens if I can't see a P wave? What happens if there's lots of P waves? Because these are all things that we see out in the community on a regular basis. But in my mind, if we can actually put this in relevance to a heart, we can then formulate a treatment plan or whatever we choose to do with these patients. So let's have a little look. Too long or no QRSs. Oh, where's my little picture? There it is. So you can tell I'm not an artist. I became a paramedic because I was never going to be the next Da Vinci. So this is a very crude picture of a heart. The black outlines the four structures of the atrium and the ventricles. The green outlines the electrical pathways. As you can see in both atriums, it goes across both sides, and the red represents the blood vessels. But we want to strip this back. We want to get rid of the blood vessels, because we're going to talk about that later. And actually, we can probably get rid of some of them. In fact, we're going to get rid of that bit as well. We're going to look at the real simplicity of it all, okay? So electricity passing from here to here, holds onto it for 3 to 5 small squares, skips across, goes down, and then goes up both sides, okay? Now, the question that we posed ourselves was, what happens when the PR interval is too long? So we're going to use that as our base marker, okay? So let's just say that to there is our 3 to 5, okay? But let's just say, hypothetically, we have one. Over-exaggerated. So that segment there, we know is longer than 3 to 5 small squares, okay? Because we've got our base marker over here, and that's telling us that's our 3 to 5 small squares. So what we now need to do, we now need to think what's happening in the heart. Is there an issue from here to here? Well, no, there isn't, because we can see this P wave. We can see it. There it is, as we want it to be. When it comes down here, are we getting this nice sharp R wave and then the S wave go up round? Yep, there it is. We can see that. We can see it. And then, like, it's not really on here, but we'd get this wash going across, and that would subsequently give us our T wave. So is there a problem? So if I was to draw it, so we know that's okay, but this bit here isn't. Well, let's have a little think about it. We know the P wave's okay, and we know the QRS is okay. So where is the problem? Well, the problem's across this little segment here. The problem is the fact that this bit of electricity is not getting to there within the time frame that it wants. It's across this septal line. That's what I mean by septal. It means it doesn't conduct electricity. It is there to separate one segment from the next. So if I've got a problem here, well, what's happening? Well, it's almost like you could say it's blocking it. We've just found ourselves a heart block. We've just found ourselves a very simple heart block. It's too long. It's too long. Now, not all of the heart blocks are like that. Let's get rid of that word there. Not all heart blocks are like that. What you may see something along the lines of this. Now, we know if we look at our standardized one over here, we've got the same here. We've got the same here. The PR interval's fine on both of them. In fact, we've got another one over here, and the PR interval's the same. But what have we got here? We've got a P wave, and then we've gone straight into another P wave. Well, we know that's not right. We know that's not right, because the boffins have told us that's not right. We know that's not right. We've got our P wave. Yep. And then we've got nothing, then we've got our P wave. So once again, where is the problem? The problem's here. And if we've got a problem once again across this septic line, we've got a block. We've got a block because it's not crossing the septal line. And all we've done is just look at an ECG, and we figured out that in the heart there was a problem. That's it. nice and simple. Let's get rid of these bits. Good. So we're starting to the ones that are too long, but what happens if we don't get a QRS? We've already looked at one QRS, but what happens, say, if we start seeing, that's already on there, perfect. What happens if we just start seeing a P wave and a P wave and a P wave, and then some kind of weird kind of looking QRS and then a P wave? Well, we can figure out the problem. Oh, let's put that in red. We can figure out the problem. We've got these P waves. So we know electricity is going from there to there. We know it's going from there to there. We know the atrium is squeezing. But also when we've got this bit here, some kind of weird looking QRS. Let's put it in that. Or is it? Doesn't really look like one, does it? And the reason why we get these is that if electricity doesn't make its way to here, this bit will eventually fire off anyway. Let's get rid of these bits. Perfect. So we've kind of started looking at these already, haven't we? So this top one here, we can see that we've got this 6 small squares, and it's consistent across 6 small squares all the way across. So going back to the pictures I've just drawn and going back to the fact that we know it should be 3 to 5 squares, in our minds, we should now be able to know that I have got a section which is not allowing electricity through in the time frame it should be. 3 to 5 small squares. And then as we look at the next one down, we can see this PR interval slowly getting bigger. And then we've got a P wave, then we've gone straight into another P wave. Well, now we've already talked about it. We've already alluded to it. The fact that we've got a problem here. But for some reason, it just seems to be a progressive problem. And the bottom one, we've got this, where's my little cursor? There it is. We've got this normal PR interval, and then we've just dropped a beat. Well, once again, we already know where the problem's going to be. It's going to be here, which meaning is that we found a block. We found a block for these patients. And then I've put the name of this one in. So this is like a 3rd degree or complete heart block, where we're seeing these P waves going through, and then we're seeing this kind of strange QRS. We're going to get to that a little bit later in the presentation as well. And it's almost that simple. And then we have no QRSs at all. I'm not necessarily going to draw this one, because I'd like to think now, if you think about what's happening, is the SA node firing and is it being received from the AV node? Well, it is, because we can see it from one to the next. But what isn't happening? Where is it going? Well, there's nothing happening in the ventricles. So is this a block, or is the ventricles at complete standstill? So this one's actually a ventricular standstill. But what happens if the PR interval is too short? Well, let's have a little look. Let's have a little look. So where's my cursor? There it is. Good. So we already know from there to there is going to create our P wave. And the heart is very clever. This segment here, it will do its best to regulate 3 to 5 small squares. In fact, let's do it in that. We know that here it will regulate for 3 to 5 small squares. So electricity goes down here, waiting 3 to 5 small squares. But we know electricity also runs around the rest. And let's just say this sneaky little bit of electricity finds an accessory pathway, an extra loop, and can go through and connect at the bottom. So our ECG dot is here. So what are we going to see? Well, we've got the start of our P wave, and then we've got this accessory pathway. So this little accessory pathway has caused this here. So we're not seeing this. There's still electricity moving towards it when normally it'd be paused for 3 to 5 small squares here, but it's not, it's continuing. And that's why we've got this extra wave. This is called a delta wave. So now we've got a short PR interval. And it's Wolff Parkinson White. Well, these are the ones that we're probably going to see out in the community. And as you can see, I've got my, our P wave. And just as the P wave is almost coming down, we're getting that slope up and back in and back out. And that's our Wolff Parkinson White. So now we've got one that's too short. What about no P waves? What does the QRS look like then? Well, previously I've drawn them beforehand, but we're actually going to look at the examples. We're going to go back and try and explain to what's happening. So I've got 3 examples here. So the top one is atrial fibrillation. So atrium is fibrillating, so it's twitching, constant little twitching. The next one down is supraventricular tachycardia. So supra meaning above, ventricles, which is part of the heart, tachycardia meaning fast heart. So generated from above, the ventricles causing fast heart in layman's terms. And the one below, we can't see any P waves at all, but yet we get to see a wide QRS. And we're going to quickly break them down. I'm going to quickly draw some pictures. Let's get rid of all of this. So AF. So what is happening with AF? For some reason, the SA node is not working. And that could be age. We see a lot of time in age. In fact, it's just a bit worn out. We could be the fact that they've had a mild cardiac event, which means it's no longer working. There's a few reasons why it couldn't working. What it means is the rest of the neurological pathway gets nervous and it will start just firing off by itself. So we just get these lots of little bits of electricity all the way through here. And then every now and then it's picked up. Now, there's no P wave, so we can't see a 3 to 5 small squares, but it will pause there briefly, and then it will come down, and then it will do its normal thing. So what we see and so forth and so on. So where this bit is just firing off is causing this kind of wobbly isoelectric line. But there's no distinguishable P wave as per se. But once it's been captured, it will do its thing. And then we just see this wiggly little line again afterwards as it does the next one. Okay. What did I put next? SVT, Supraventricular Tachycardia. Now, what's happening with SVT is the fact we are seeing and so forth. Now, we don't know if there is a cheeky little P wave hidden somewhere underneath these in relation to them. And the reason being is because it's going so fast. It's going so fast that they're overlapping. So we're not too sure. Now, there is a way to know whether it's SVT or not, and that's to do with the width. We're going to cover that in about 10 slides' time. Perfect. And the next one was, so the next one here. I like this analogy. I really like this analogy. So I'm a big fan of dance music, and our SA node is the DJ. And he is playing a really good tune. And what he does, he keeps everyone in sync with that tune. So you can have a nice loud bass bit of music and it comes down here, everyone's really excited, and then it passes down here, and then it loops down, and then it does its normal bit as it kind of goes back up. Okay. So because of that, when we have a DJ, we have everything nice and neat as it goes through. Because when your heart beats, you want it to beat with a sudden beat. You want a strong, powerful pressure. You want to squeeze it hard. You want synchrony. You want to push that blood out. Now, let's just say the DJ decides to go for a cigarette break. And all of a sudden, we don't have that. And meaning we don't have that there. But this bit here is now standing in the second room down. It can't hear anything anyway. But it thinks, you know what, maybe I should have a little bit of a dance, or maybe just have a little bit of a shuffle, because I still have a bit of excitability. So it beats. But what happens, where before we had this strong beat. We now have this very relaxed, slow as the heart beats. Okay, and that's not good, because when we look at a heart, when we look at an ECG, if we were to draw this on an axis, that is size and this is time. And the one thing we don't want, we do not want a wide beat, because it means it's moving slowly. It can't generate that pressure to push the blood out. And if it can't generate the pressure to push the blood out, this patient could be pulseless, or they could have a really weak pulse. Their blood pressure could be through their boot. And that's not a good thing. We don't want that. We don't want that. We want a nice sharp beat. Let's get rid of these bits. Okay. So lots of P waves. Now, through what we've already discussed, I'm hoping you can look at the top one. I know I'm not interested about whether you know the name of it at all, but if you were a pre-hospital clinician and you looked at that and you're kind of thinking, well, where's my little cursor gone? There he is. We've almost got this that could be deemed as a T wave, but otherwise we've got lots of P waves, lots and lots of P waves, lots and lots of P waves, and then we're getting QRSs and then a T wave afterwards. So once again, if we were to almost draw it, we'd get this P wave, P wave, P wave, P wave, P wave, hold on to it for 3 to 5 small squares, pass down, run down, and then beat as we would expect it to beat. We kind of know that, but that's not right, is it? We know that's not right. And as I say, I'm not too worried about whether you know the name. Like the name of it's atrial flutter, but I'm not too worried. And the bottom one, I'm definitely not going to draw this one. We're seeing a P wave, then another P wave, then another P wave, another P wave, with no QRS complexes at all. Well, we already know now, just from what we've already discussed, if I'm seeing lots of P waves and no QRSTs, well, that tells me the ventricles aren't moving. So the actual term for it is ventricle standstill, but they're just not moving. It doesn't make any difference. They're not moving. That's a killer, you know. If ventricles aren't moving, the heart's not beating, they're not pushing blood, they have no blood pressure, no brain perfusion. It's not good for them. And I've also, we're kind of just going back to third degree, because part of it was the lots of P waves for the QRS. And this is just simple fact that what we're seeing here is complete disassociation and synchrony from one to the next. I am now going to put a complete block here. So we know this is going to beat at its normal rate. We know it's not going to cross over this bit, but we know that this bit is eventually going to say, you know what, I probably should beat, so it does. And that's due to its, so it kind of beats around. And that's due to its action potential and so forth. Okay. Good. And then, so, you know, quick considerations. Just by understanding those very, very simple principles of P to QRS, we know if it's long or varied, it's going to be some kind of heart block, or ventricle standstill if there's no QRSs at all. If it's a short PR interval, it's most probably going to be Wolff-Parkinson-White. If there's no P waves, atrial fibrillation, supraventricular tachycardia, or super or above ventricles fast heart, pacemaker, we're going to cover that in a moment or two, or atrial standstill, lots of P waves, atrial flutter, ventricular standstill, or third degree heart block. It fits nicely into that. So that's just our PR interval. Now we're just going to look at the width of our QRS. So a normal width is between 70 and 100 milliseconds. Well, for me, I always like to work on these 3 small squares on the paper, because in my mind, I'm a very visual person, and I look at that and go 3 small squares. If it is narrow, if it's narrow QRS, we can assume, or we can determine, the origin of it is either the sinus, atrium, junctional, and sometimes the ventricle, if it's narrow and complex. Now, what does that mean? So let's go back to this. Yeah, I've got on that one. If it is generated from here, going back to that DJ analogy, pumping the beat down, 3 to 5 small squares, good excitability, meaning we are then going to get this lovely narrow QRS, okay? If for any reason that is not working, or we can't necessarily see a P wave, and it's coming from here, what we may still see is no direct P wave, but we may still see a narrow complex QRS. If it's generated just below, we might see the same. If it's generated down the bundle of hisses, the bundle branches, it definitely gets wider. Okay. And once again, we're not really going to hammer home exactly why, because I say that's going to be session 3 or 4 later on down the line. This is just talking about the principles of. So when we look at the width of a QRS, when it's narrow, the rate for us becomes more important. Is it a normal rate? Is it too slow? Is it too fast? Yes, hypothermia can sometimes cause us to have this slightly wider QRS. But when it's wide, it becomes a bit more of an issue, as I'm more related to hypothermia, and lots of other things can cause it to be wider. But say, going back to narrow, we already know SA, node, atrium, or AV junction. If it's wide, it could be generated from a few different places. So examples of narrow, I'm not going to draw any of these. We've got our sinus tachycardia, normal sinus rhythm here. We've got our sinus bradycardia here. I'm sure some of you have probably noticed the T wave is slightly funny. We'll cover that if we want to cover bradycardias in session 5. We've got our sinus tachycardia, and we've got our supraventricular tachycardia. Above ventricles, fast heart. The P wave could be there, but it's just a bit hidden. But we know it's narrow, so we make an assumption it's coming from above. Wide QRSs. It's not normal, but why? Well, these are 3 examples that we put up. This one is ventricular tachycardia. So ventricles going fast. Okay, we've got this wide complex. This next one down is 3rd degree heart block. And this last one here is a paced rhythm. So let's have a quick look. Let's have a quick look at some pictures. Now, we know that we want it to go from here to here, 3 to 5 small squares, skip across, and then run down here, and then go all the way up. That's what we want. But what's actually happening is, for some reason, on ventricular tachycardia or super fast ventricles, this bit here, I want to do it like that. This bit here is just squeezing of its own accord. Now, normally we just want it to squeeze upwards, because that's the whole point of these pathways as they are. But that's not happening. What's happening is that we're getting these just squeezing all the way in from each side. It's synchronized, but not in the way that we want it to be. It's almost like if you put the heels of your hands together and squeeze to your fingers. That's how we want the heart to beat. We don't want it to have this clapping motion. Now, because of that, we're just getting this electricity going in and out, in and out, in and out, in and out, in and out. And that's why we get this wide, big rhythm. Now, 3rd degree block, we've already talked about. This bit here is firing off. This bit here is blocking it. And at some point, this has got to fire off. And it's slow. And we don't really, it's not really happy. It's sort of like just slowly squeezing because of the action potential. So pacemakers. Throughout all of these sessions, we don't really cover pacemakers that much. If you want to, feel free to put it in the comments and I'll do a session on pacemakers. Or I'll do like a 10-15 minute on pacemakers. Because once again, it's that we go to someone with cardiac symptoms, they have a pacemaker. We should really be trying to convey them if they want to go in. But what they have this kind of little box. And then what the cardiologists do, they then attach a number of different wires. And depending on where those wires attach will determine the shape. So let's just say the pacemaker is generating from here. What we may see is this narrow complex. let's just say it's generating from here or somewhere here, we may see a wider complex. And that's just because of the way the pacemakers work. Let's say if you want me to talk about a later date, give me the feedback and I'll see what I can put together. I know we didn't talk about it before, but I just thought it's worth us just having a quick look about what causes a wide QRS, bundle branches, chemical imbalance, poisoning or antidepressants. Wolff Parkinson White, you could argue, is a wide QR, well, not argue, it is a wide QRS. Pacing externally or internally, being cold can cause wide QRSs, and sometimes rate-related VTs, as we've already looked at in an example. So ST segment changes, why? I'm not going to spend too much time on this because there's a whole session of it at a later date. Now, I've done this picture here very crudely, but what I'm now going to do, I'm now going to add in the muscle tissue. I'm just going to draw it around here as well. So this, everything inside that blue encapsulates the muscle from one side to the other. So just so we're kind of aware, this is where the blood would fill up and that's where the blood would be ejected out, okay? But what we do need to do, we need to attach some blood vessels to it. Now let's just say hypothetically that this blood vessel is knocked out and it is taking out this section of heart. So this is where we're having our myocardial infarction or heart attack, and it is stopping this. Now what you've already, or hoping you've noticed, that we've actually knocked out some of the neurological pathways here. So what it will do, it will just make another little pathway, which may not be as fast, may not be as effective, but it will still manage it. So that means when we see something, it's still moving towards, and all of a sudden, we have a change. We have some ST segment changes. Okay. As I say, I'm not going to do too much because we've got a whole hour of it at a later date. So when we talk about it in, I'd say number 4, number 5, I think it is, we'll really start to drill down about why we get this elevation, depression, reciprocal changes. We'll also talk about left and right bundle branch as well. We'll also talk about rate-related ST changes as well, because I think those things are really important. And having a whole hour, you know, give me a few hours and we'll probably won't cover enough, but so we'll save it for them. T-wave changes. T-wave changes. So, yeah, we've got that one. We know we've got it from here to here. We know it's going to hold on to 3 to 5 squares. We know it's going to shoot down here. We know it's going to come around here and go up. So that has given us our, oh, no, we don't want a T-wave just on this one. So it holds on to it about 400 to 500 milliseconds, but that just allows the ventricles to push all the blood up and eject it out the heart. And then once it's done that, it needs to get ready for the next beat. And the best way I describe it to students is we almost get this wash of it going across the top. It's a little bit more complex than that, but I think that's the easiest pictorial we can use. But what is actually happening? So what we're doing, this picture here represents the muscle bit that we drew earlier here, okay? And these are blood vessels. These are blood vessels on the outside, okay? And obviously there's going to be the little bits of blood vessels that are going to feed the rest of it. So when the heart beats, electricity is going to move in one way. And because the blood vessel is so close to it, it can organize the chemical rebalance even quicker. So it goes back. So that means we know we're going to see a nice T-wave. Now let's just say I put a obstacle course in the middle of it. Now what we may see is a normal QRS. But actually, we get this bit here, and then it stops. It can't go any further. So it has to come from the other side. So we would see this. So biphasic, so one up, one down. Oh, no, shouldn't be drawing that. Oh, no. Oh. Okay, let's just come off the screen. So when we talk about T waves, going back to just what I've just drawn, we know we're going to get our P wave, Q wave, or that bit there, our RS, and it's the negative moving away from the positive, and that's why we're getting this positive up. Right, let's see if this is happy now. Oh no. Okay, we'll scrap that. So when we look at T waves, we want it to be normal. So looking at the picture on the right hand side, we've got this normal, we've got this up and down. And I'm not too worried about whether this up and down has a slight kink in it, has a slight notch in it. I'm not worried about that. I just want to see this up and down. What I don't want to see, I don't want to see these tall T waves. And on the picture or example we've got here, this T wave is bigger than the QRS. I don't want to see these biphasic T waves. I've just done a very simple pictorial about what could cause a biphasic T wave. Something is happening in the heart. We don't want to see inverted T waves. Definitely don't want to see, we want to see a T wave. And I've just put on the screen a simple reason of what could have caused it. So normal, we've got the tall chemical imbalance, possible start of an MI, biphasic, heart attack. There could be a couple of the reasons, but heart attack for us pre-hospitally, we're always going to think heart attack. Inverted, struggling with the lack of oxygen. So ischemic is the medical term we would use. Flat, we've got to consider there's no repolarization, because that's what they tell us. If there's no T wave, there can't be repolarization. This patient may not be pulsed. There's a phenomenon called R on T, where everything looks fine, but all of a sudden these T waves are disappearing, and actually they're really poorly. But all we're doing is looking at the screen. Sometimes we don't look at our patients. Okay. So hopefully that was a quick whistle-stop tour of everything, of the principles of an ECG. And for me, like when I talk about ECGs, I always think as long as I understand those key elements to it, I can figure out what to do with my patient. And in a pre-hospital setting, in an ambulance setting, we have to understand what that means. Can I leave this patient at home? Can I leave this patient at home and refer them to the GP? Should I be taking them to hospital, or encouraging them, I should say, to go to hospital? Should I be blue lighting them to hospital? Should they be going to the nearest cath lab to have a stent fitted? Or are they high risk of attack, or is it cardiac arrest? So as I say, those are the principles. And going through the following sessions on each one of those elements, we're really going to start drilling down and looking at what causes it, what we need to do, what we need to consider, treatment plans, all of those things in the subsequent sessions. So thank you very much. Hope you enjoyed it. Hope you learned something, and sorry for the slight technical difficulties. Oh, I need to hit. Can you hear me okay?
Yeah, I can hear you, Ben. Perfect.
I can't seem to stop the share.
Let me stop for you. It's one of the issues is once you've got something, stop participant sharing. There we go. Once you get a few windows open, it just goes. You'll lose it altogether. Don't worry. I've got all sorts of fancy Stream Deck buttons, and it just still complicates me.
Good, Karen Clark. Thank you very much. The pen is Karen. I'm good, Karen. I'm going to say this now. I'm glad the penny dropped, because this is how I work with a lot of myself. This is my style of teaching. If you now watch the remainder, I would say you'll become a good pre-hospital ambulance type clinician for ECGs. Okay. M. Bracken, thanks, great. So looking forward to the next one. Awesome. Thank you, Rebecca. Thank you. Is Andy Collins still on here? We'd love to know what he thinks about it being, or used to being still one of my bigger bosses. Thank you. Look forward. Very interesting. Good. Thank you. Good session. Will, I'll catch you soon, mate. Good to see you. He's at my station. And he called an awesome Ben. Great stuff. Oh, Emily, is that Emily from Brighton? Emily Payne? Great presentation on the basics. I love your presentation style. Good, Jane, I'm glad you enjoyed it. You know, keep watching them, and they're all very on a similar thing. No potatoes. No, we had to stop that. That caused an injury. I'll talk about that another time. Excellent, excellent. Thank you. Really helpful, really helpful. Ben Lamb, CCP, still forget. Good. Nice. Cheers, Ben. Does anyone have any questions for me?
There's just 3 in the Q&A box. Have you seen the ones from Mick, Nadia and Gareth? I don't know if you can see that box.
I'm not very technical.
I'll tell you what, don't worry. I'll be the facilitator and I'll read them out.
Okay, go on then.
Emma's asked, in short PR interval accessory pathway, when the impulse eventually exits the AV node, will it cause an RSR complex?
So if we kind of think about what's happening with, so an RSR complex, so we're almost talking bundle branches of that one. So when we talk about accessory pathways for PR interval, we're kind of more focusing on this Wolff-Parkinson-White. So when we talk about RSR, we see that more in bundle branch blocks. And that's because the heart will actually flip the electricity from one side of the heart to the other. And it's actually slow. And depending on where it flips it, means that we then get this separate RSR. And it depends on which R is the big R, then determines where our block is, if that makes sense. Probably not. If you watch the session about the wide QRS, we talk about that, and I will talk about right bundle branch block and the shapes, and we will look at RSR waves. Is that your question? Does it answer it? Put it in the chat.
I think it does. But next question from Nadia: fast AF versus SVT.
Okay. What are we having a race? Who can go the fastest? Or so, so AF, out of all of these sessions, AF is something that we don't necessarily cover. Now, when we talk about AF, if you really drill down about the difference between, or what AF needs to be AF, it needs to have no distinguishable P waves. It needs to be irregular. And the third one, which we kind of forget, is the QRS complexes are different sizes. So now if you were to get a fast AF and an SVT, and let's just say they both look very, very similar, how would you distinguish between one to the next? And I would say, look at the size of the QRS complexes, because that could be your determination of whether someone is in fast AF or in SVT. Now, there is two, I've been around the block a few times. I've spent, I'm so grateful for, my ambulance trust giving me the education that I've got and actually learning about the treatment plans from one to the other. For someone in SVT, their treatment plan can be pretty brutal and pretty nasty. If someone's in fast AF, they can actually get very subtle management and it's actually very easy on the patient. But if you want me to talk about it more, I can do more about it in session 5. Drop an email to the CPD guys and we can, I can do a little brief of the two differences if you want me to. But does that answer your question? Look at the size of the QRS. Is it varied? Then we've got to question, really, I'd really suggest that's your fast AF. If it's consistent, that's your SVT. Any other questions?
That's exactly how I remember it, Ben. You're absolutely right. Gareth has said... Go on, sorry.
Go on. No, go on. I was just waffling.
Gareth has said, if Ben isn't doing it in one of the other sessions, could he possibly discuss AVR on the ECG and whether there is anything significant that AVR can tell us? Even in university, they seem to avoid AVR.
So AVR, when I teach ECGs, AVR is negative. That's it. AVR is negative. So if you actually look at, if you're using my head as the heart, lead 2 is here. AVR is not a complete opposite. It's actually slightly off. Okay. So AVR is the only one where one view, if you have ST segment, elevation or depression, they could be having an MI because it's the only dot that looks at that particular part of the heart. However, when I teach it, it needs to be negative. If it's not negative, you should be taking them to somewhere for them to decide on what it is. It is not a PPCI job at that moment in time because it needs to be in 2 more views. It needs to go to your local ED. If cath lab's only 5 minutes further, maybe you should take them to that ED. That's you knowing your area and how the patient presents. If they look terrible, go to the one with the PPCI. If you think they look okay, maybe take them to local. That's down to you. Negative is the plan. Anything above the line is not good. Is not good at all. Okay. And as I say, that's kind of all I really kind of get into. Does that? I hope that answers your question.
I think it does. Yes, just pop in the chat, Gareth. I think.
Check the leads. Yeah, are they transponded? Yep, good. As a CCP, can you offer assistance on administration drugs for certain arrhythmias for on-scene paramedic adenosine for tachycardia? So, as I say, this one's about principles. We're going to talk about management plans later on, and we can talk about tachycardias and adenosine. We don't do it pre-hospitally. And part of the reason is that if we misdiagnose an SVT and we give someone adenosine, we're going to we won't have to go to the gym that day because we'll probably be doing some chest compressions. So there's a risk associated with it. And for me, I would personally not feel comfortable giving adenosine to someone with a tachycardia. Me as a CCP, if they're shocked with an SVT, I have the pleasure of giving them ketamine and then cardioverting them. I haven't done it yet. We only do about 5 or 6 in the trust a year. And before I do it, I'm going to definitely be speaking to someone a lot smarter than me to make sure I'm doing the right thing. I would not be comfortable doing it as independent. I hope that answers you. We tend to try the modified Valsalva. It has 90% accuracy rate so far. So modified Valsalva, yep, it's great. If it's done properly, it works really well. It's worth, from a recent experience, have the pads nearby, as I did a modified Valsalva and they went into a pulsed VT. So it's always worth considering that. Granted, they terminated the pulsed VT, which was great, but boy, that was definitely an eye-opener for me. Thank you for great place. Looking forward to the next presentation. Cheers, Adam. Any more questions? Any more?
There is one from Dawn. Can you ever see a P wave in AF?
So Dawn, there's more than one type of AF. We are like pre-hospitally, we're just sort of like, they've got AF. You can have like proximal AF where it kind of comes and goes. The principle of behind an AF is the fact the SA node is not working. So throughout any pathway in the heart, you have action potential. And if it's not acted upon, it will act independently. So if there's no P wave to act upon it, it will do its own thing. So if they're a known constant AF, you should not be able to see a P wave. If you see a bump, roughly 3 to 5 small squares before the QRS, it's probably coincidental. It's probably that bit next to the SA node could be firing and pointing in the right direction at the right time, along with a few others, all at the same time to give us our P wave. But if they're in constant AF, you shouldn't be seeing a P wave because that's one of the diagnostics for it. I hope that answers your question.
Fab. Thanks, Ben. Next one is from Louise, who's saying, when is session 2? There it is, Louise, on screen now for you. Get
11th of Jan. Quick. 11th of Jan. So 11th of Jan, the whole point. Yeah, the whole point of this one, we are looking at AV blocks, first, second, third AV blocks. We also talk about right and left bundle branch block. We also talk about bi and trifascicular block as well. Okay, and there are some very simple tips and tricks to not tie yourself up into knots. I've also added in Wolff Parkinson White. We're just kind of going to look at it a little bit more. We're going to look at the re-entry Wolff Parkinson White. I haven't decided about whether we're going to do type 1 and type 2 Wolff Parkinson White, because once again, it doesn't change anything for me. I'm not, they've got Wolff Parkinson White and chest pain. Well, you're going to hospital, or I'm going to encourage, obviously I can't force them. I'm going to encourage them to go to hospital, because that's what they need to do. They need to know, because if I don't know what's going on, that's why we have big white buildings with smart people, or I refer it to Andy Collin, who knows a lot more than me. Electrolyte imbalance would be great. So So yeah, when we talk about electrolyte imbalance, are you talking about T wave changes, or are you talking like a T wave change is probably where we're going to see it maybe a little bit more? Or are you talking about QRS changes? Are you talking about drug overdoses causing electrolyte imbalance?
We'll add it to the list,
So
Ben, of maybe to discuss. If you
yeah,
like.
so email it in, And thing is, if I get like 20 different requests, I'll look at what's the most common, and then we'll try and squeeze it into an hour.
Fab. Yeah, pop that in a message to us, Sean, and anybody else, and we'll convert them into maybe a webinar for the future.
Yeah, thank you for a cool session. Got to go. That's fine, Sean. Brilliant. Any more for any more?
We've got one question from David. Can we trust this? This actually is going to create an interesting debate on the chat. Can we trust S1Q3T3 in relation to suspecting a PE? And how reliable is it? No,
I don't.
Excuse me.
So if I think someone's having a PE, I'll do an ECG as per standard. If they've got it, then we're moving towards it. For me, it's this kind of presentation of how they are. And I think because I don't know what the sensitivity is for the ECG changes on it. And that's why I don't overly worry about it. Yeah, so someone's put on there S1Q3T3 is a very late. But then we've got to remember sometimes people wait hours for ambulances. So it depends on what you mean by late. Thank you for answering this. Yep. They do in Cornwall. Yep. Some people do as part of their management plan. For me, as I say, it's this presentation. You go to a reasonably healthy person whose oxygen sats for whatever reason are not getting above 94 they're not COPD, they're not asthmatic, they haven't just been smoking loads of cigars or something, or they haven't got COVID or any of those types of things. They're going in, or they haven't got a chest infection. They're not hitting any of these. They've just got slight shortness of breath. Yeah. Struggling to call your CPD. Oh no, that's not you, is it? Good.
That's me.
I looked at the evidence. Only shows 20. Yep, good. So they put 20% of patients with PEs at time. Yep.
I've got one from Jane. Did you cover QTC changes primarily associated with antidepressants?
So So we can, if you want, we can add in a little bit of toxicology in the fifth one. Now, I guess you're talking about, for a woman, it's 430 milliseconds. For a guy, it's 480. Anything above that, we have to be suspicious whether they've taken an antidepressant overdose. Hopefully the history will get us there. That's what normally gets us there, to see whether they've had an overdose, or whether it's from the patient or whether it's by the paraphernalia that's around them. There sometimes can be a little bit more to it than that as well, like a widening QRS. I don't think it's not something that I would predominantly look for straight away. And in my world, if I've gone to someone who's taken any overdose of any kind of form of tablet, wasting time doing a ECG may not be in their interest. If you've got activated charcoal, great. These people need to be in hospital. If they've taken, in their low GCS, then they need to go to hospital quicker. And I think that's more important. Sometimes, sorry, I feel like I'm going to go on a rant now. In my time in the ambulance service, I feel sometimes we've lost the magic where we literally need to pick them up by their arms and legs, chuck them in the back of the ambulance and drive quickly. I think we have all these great skills, which are great, but sometimes we just need to, if they've taken a large overdose, put them in the back and drive. I know it's a cop-out answer, that, isn't it? An absolute cop-out answer, but that's only my practice. That's only my practice. I'm not saying that you have to do the same.
I think it's sometimes the right thing to do, Ben. I think we have. You're right. Ben Mel just put too much faffing about on scene sometimes, crossing T's, dotting I's, PRFs, and I see that.
Yeah, and book a paperwork delay when you get to hospital. Yeah. Sometimes we just need to go with them. Any more for any more?
We've got one big sick, apply diesel, Tom's put. One more question from Tamara. Who's the fastest driver, I used to say. Yeah. Tamara said, people talk about high takeoff, but I've never been sure what this is and why. I'm not sure whether you're going to cover that in another presentation.
So I'm going to look directly at the camera. They have ST segment elevation. Take them to somewhere where it deals with ST segment elevation. Okay, and it's as simple as that. Like if someone was to show me an ECG and it was high takeoff, I would probably sit there going, yeah, it's high takeoff. But my employer, and rightly so, would say if someone has ST segment elevation or 2 or more views, they should be referred to PPCI and they should then deal with it. And once again, it goes back to this anomaly of, are we faffing around too much? It's almost like pericarditis as well, isn't it? It's this, well, they've got a spodic sign. I believe it to be pericarditis, but they've also got ST segment elevation. My uncle had pericarditis. He still went to PPCI. He wasn't having a heart attack, but he still went to PPCI. And it goes back to this. Sometimes the A&E doctor doesn't know, so refers it to the consultant. Consultant then refers it to the junior cardiologist, blah, 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 blah. If they meet the criteria, ST segment changes, you are to follow the ST segment guidelines. Specificity, sensitivity. Stand in front of a grumpy PPCI doctor and get it wrong, as opposed to take them to somewhere that doesn't have PPCI. Sorry, I feel like I'm ranting again. Sorry. And that's it. So high takeoff. If you do want to request it, I'm not going to talk about high takeoff. It's because it's ST segment elevation.
Fabulous. Ben, thank you so much indeed. What a fascinating subject. And also, we have got session 2 coming up shortly. So please scan that QR code, get booked on 11th of January. You'll be all recovered after Christmas and ready for some more positive learning. So awesome. Make sure you scan that QR code.
Really interesting. Thank you. No, thank you for joining my sessions. I know I waffle too much. Thank you.
We've got a couple more webinars coming up shortly. So on screen now, we've got one on the 21st of December, which is Jason on personal brands. And we've got another webinar on the 23rd of December. Gosh, it's almost Christmas Eve. Assessment of a feverish child by our consultant paediatric specialist, Dashana. So scan that QR code. We've already got 1,000 people, I think, registered for that plus. So make sure you join that. Then we've got Ben again. It's almost like it's rapping almost at this time of night. January 11th at 8 o'clock. So please come for part 2 of pre-hospital ECGs. And then we have got Dr. Dashana presenting a Saturday morning symposium from 9 o'clock to 11 on Saturday the 12th of March, spotting a sick child. And she'll be covering everything from spots and rashes and illnesses from big sick to little sick of kiddies, anybody under the age of 12. So that's a fabulous little symposium there to come and join us. All our webinars are available at cpdb.com/webinar, so please download the app or jump over there. If you do download the app, you can literally register for the webinars with one single click, and it just makes it super, super, super easy. So, Ben, all that leaves me to say is have a fabulous Christmas, and thank you so much for tonight.
No problem. I'm glad everyone enjoyed it. Sorry for the slight technical issues at the end.
Don't worry. By the time I've chopped and changed the recording tomorrow, it'll be perfectly polished. So these things happen. Don't worry at all. Don't worry. So on behalf of myself and all the team here at Trauma Care, if you're not going to join us for another webinar, please have a very Merry Christmas and a great New Year. If you are working tonight, stay safe and thank you for the great efforts you're doing out there this evening. And if you're not working, kick off your slippers, enjoy the rest of your evening, and thank you so much indeed for supporting us here at Trauma Care. And Merry Christmas, grab yourself a glass of sherry, maybe a cup of tea, or even a mince pie, and have a great evening. But thank you so much indeed, everybody. And thank you, Ben. Stay safe, buddy.
Nice one. Thanks a lot. Take it easy.
Take care. Bye-bye now.